I'm Dr. Bryan Kelly. I'm the chief of the sports medicine service at the Hospital for Special Surgery, and today we're going to be talking about arthroscopic treatment of femoral acetabular impingement in the hip. This will be chapter 1, which will discuss portal access. This is a lateral radiograph of a patient with femoral acetabular impingement. He has a large cam lesion with an alpha angle of approximately 80 degrees. This is a right hip that we're looking at, and we are now going to start access to the hip. Two general portals are used at the beginning. The first is an anterolateral periotrochanteric portal, which is now being accessed. We're going to enter through the soft tissue using a clamp, and now a spinal needle will be introduced into the hip joint. We can palpate the edge of the capsule prior to introducing it into the joint, and then fluid is introduced to confirm that we have accessed the hip joint. A guide wire is then placed through the 17-gauge spinal needle, and we can palpate the fossa of the acetabulum. Fluoroscopic imaging can be used to confirm appropriate positioning of the guide wire. A cannulated cannula is placed over the guide wire with an atraumatic hip to prevent any iatrogenic injury to the cartilage surfaces of the femoral head and the acetabulum, and then a 70-degree scope is placed into the cannula to allow for visualization of the inside of the hip joint. Flow is introduced to try to clear out any blood in the joint to allow for visualization of the anterior triangle. The second portal that is established is the anterior portal, which is typically placed approximately 3 to 4 centimeters distal to the anterior superior iliac spine and approximately 1 to 2 centimeters lateral to a perpendicular line dropped from the ASIS. Again, the spinal needle is introduced. We've confirmed entrance through direct visualization and good flow of fluid out through the spinal needle. The guide wire is then introduced, and again the atraumatic cannula is placed over the guide wire, and in this case, under direct visualization, the cannula is introduced into the joint. Now with two portals accessed, we get good flow into the joint, and the joint will begin to clear so that we can see the inside of the joint.